Welcome back to Gentle Dental. I'm Dr. Sarah Chinnery, and today I'm joined by my friend and former colleague, Alison Koehler. Alison's journey in dentistry is such an inspiring one. She started her career as an expanded function dental assistant, where she mastered hands-on skills and patient care from the ground up. Her passion for helping patients and her love for learning led her back to school at Ozark Technical Community College, where she earned her degree as a dental hygienist. I had the pleasure of working alongside Alison for several years, and I can tell you firsthand, she is not only an incredible clinician, she also is an amazing educator. She has a gift for breaking down dental concepts so patients truly understand their oral health and feel empowered during their visits. I'm so excited for you to hear from her today, learn from her expertise, and get a behind-the-scene look at the role of a dental hygienist. Alison, can you introduce yourself?
Sure, Dr. Sherry, thank you so much. My name is Alison Koehler. I am a practicing dental hygienist. I've been in dentistry for 13 years, the first 5 as an expanded functions dental assistant, the last 8 as a registered hygienist. I'm currently practicing as a hybrid, which means that I am doing restorative functions with a dentist as well as hygiene functions.
What made you decide to go back to school to become a dental hygienist?
Honestly, I fell in love with dentistry. So when I started as a dental assistant, I will be completely honest, I was just looking for a way into a 9 to 5. I was young and I just needed a job, and I randomly, maybe not so randomly, chose dental assisting, and I fell in love. The difference that you can make in somebody's life through dentistry is huge. And I wanted more. I wanted to be able to do more. Outside of going to dental school, dental hygiene was the next thing.
Can you walk us through your educational path and licensing process?
It's the hardest thing I've ever done in my entire life. So educational path, because I was already a certified dental assistant, so what that means to have a CDA, I have already gone through a course of education and taken a national board. And so having already had that, I had some courses kind of under my belt that would have given me almost all the prerequisites I needed. So there was 5 science classes that you have to take before you can even apply for a dental hygiene program. The program itself, you can either do an associate's program or a bachelor's degree program. I went with the associate's degree program through OTC. It's a full 92 credit hours, just like most associate's degrees. But the amount of sciences involved in that, so we're talking oral facial anatomy, histology and embryology, periodontology, oral pathology, infection control, radiology, like it's all dental classes. Like it's not fluff classes. And then to be able to sit for boards, 2 boards, you have to obviously graduate from that accredited school. We take national written boards. We take regional clinical boards. And at the time, we were still testing on live patients. I know that is changing in a lot of parts of the country, but I had a live patient for my clinical board. And then maybe 3-4 months after that, you get your license.
It's a grueling process for sure. Is there a moment in your career that really stands out to you or shaped you how you treat patients?
100,000%. Shortly after I got my license, I moved from the city in which I graduated from, and I took a job in public health. Public health is underserved, and when I took that, I also learned that it was severely undereducated. So the disparity of disease and the need for patients was so high that the level of compassion that I had for patients, not just because of their condition, but because the education is not there and the resources aren't there. The access to care is not there. So it was a lot of doing the best we can given the circumstances, and I think learning to treat in unideal circumstances was huge for my career, because you learn to explain things differently. You become more relatable. Learn to say it's okay to not be at 100% because 60% is better than 0.
Mm-hmm.
And learning that in some cases, some families are sharing a single toothbrush, if one at all. The level of need, and then adapting your practice to serve in the best way that you can. We're taught that you need to treat at this level. I'm like, well, that level isn't always an option.
Can you explain like a big picture of what a dental hygienist does?
Absolutely. So dental hygienists are prevention specialists. We are not dentists. We do not diagnose, but we help to mitigate your risk factors for progressing disease. What that means when you come into a dental office. We are going to be looking for things off the bat that are different from initial scope of what a dentist is looking at. Yes, they look at everything, but what we look for is signs of infection in the gums, bone loss, bleeding, inflammation. We're also there to educate. Let me tell you how much time dentists don't have. have to educate patients in everything that they need to. It's just not feasible. So hygienists are meant to preventatively treat patients. We can therapeutically treat in cases of periodontal disease. We are also meant to educate our patients on ways that they can improve their oral health or oftentimes their overall health, since it's all related.
You guys are very, very important. And I'm always thankful when I have a hygienist that is willing to take the time to educate and things that I wish that I did have more time to do. What should a patient expect for a typical hygiene exam?
Exam, assessments first. So we're going to ask you about your health, your medications. If you try to tell us that it doesn't matter, it does. Absolutely 100% does. We're going to take x-rays because if we can't see it, we can't assess it, we can't evaluate it. And oftentimes we're looking at the bone and you can't see that visually. There's tissue covering your bone. We are going to probe the gums. A lot of patients see this as you're poking around in my gums. Yes, kind of. And if the gums are infected, sometimes it can be uncomfortable, but it is necessary. And I promise you, we're not trying to hurt you. We're just trying to give you the best treatment that we can. And until we know the situation in which we're working in, we can't do that. Assessments, health history, patient trays, evaluating the current condition, depending on what the condition is. If we're in a healthy, fabulous state and we just need some regular cleaning or prophylaxis, then we can typically continue on with that depending on appointment length. And if it is more involved in that, usually there's some treatment planning involved, kind of lets you know what next steps would be. Usually it doesn't happen same day unless there's a special circumstance that allows that time. Sometimes there's insurance pre-authorizations and the hoops that we have to jump through to be able to provide care. But usually 2 parts, assessment, treatment, if time allows.
Whenever you're going to an appointment, people don't understand what the appointment is there. They are just here for a cleaning. And there's a lot more of the background that isn't actually talked about. For us, a lot of times we're allotted 1 hour. If you're 15 minutes behind schedule, then you only have 45 minutes. And then it takes 20 minutes to get health history and x-rays. And then that only leaves you about 5 to 10 minutes for an actual cleaning, which isn't enough time to actually do. And so I'm hoping that this kind of helps people understand that we're not the bad guys if we need to reschedule even just for a cleaning, because you're not getting a good cleaning if that's the case. So it's just kind of that balance of making sure the medical side, we're getting all that information, we're getting the clinical diagnosis aspect, being able to actually do what we need to keep your teeth healthy and clean.
Yes, all of that. We are not superhumans. Honestly, if a patient is late to their appointment, we get it. Life is life, but you have to understand too, we want to do a great job. And if we don't have the time to do a great job, we can't.
What are some common misconceptions patients might have about your job or just cleanings in general?
First and foremost, we are not judging your teeth. We are not judging you. We are not judging the length of time since the last time you came to the dentist. We are genuinely happy for you to be there. That first appointment is usually the hardest one, especially if it's been a long time. We understand that coming into the dental office, laying back in a chair and opening your mouth is a extremely vulnerable position to be in. The majority of people do not want to be there. We get it. We're here to help. We are genuinely here to help. Most people in dental have a heart of service. You don't have to tell us you hate us. We love you too. But on a lighter note, hygienists are not out for your blood. We are not intentionally stabbing your gums. We do work with sharp bladed instruments, but the majority of the time when your gums are bleeding, it's because of infection, because infected gums do bleed. Also, your gums are going to be sore after a cleaning and sometimes during the cleaning, especially if they're infected. Similar situation, if you had a cut on your hand and you went to go wash your hands and you got some soap and water and you were really cleaning out that cut on your hand, it's going to be a little sore and a little achy afterwards. You're flushing out that infection. Same thing with your gums. So we're not here to hurt you, genuinely trying to help you. A lot of times I'll hear recommendations that I'll make and it's well, my insurance doesn't cover that. I'm sorry. That really sucks. That doesn't mean you don't need it, unfortunately. We as dental professionals aren't the bad guys for the insurance situation. That's a different entity entirely. And if as dental professionals, we cave to allowing insurance to dictate treatment and say insurance only pays for this, so we're only going to recommend that, that's not good healthcare. So just because your insurance doesn't say they're going to cover it doesn't mean you don't need it. Yes, we understand price issues, cost issues. It's an access to care issue. That is not something that dental professionals, clinicians can solve that problem. So we are going to tell you the best thing for your oral health. If that isn't possible, maybe we can say, well, in the meantime, we can do this, or doing this at home can really help your situation, but don't involve us in an insurance battle. They're two separate things.
Here is plan A, and that's the best case for you. If we can't get there at this point, we can go to plan B and hoping that we can get to plan A soon, kind of thing. We try and work with people. I don't think that we're cutthroat on that kind of stuff. What are you looking for when you do an oral exam?
Oral cancer screening, so that's that first part of the oral exam. Typically lumps and bumps that shouldn't be there. So we're feeling around your tissue. We're looking for discolorations, white spots, ulcerations, trauma areas to the tissues. And then after that, goes into that periodontal assessment, specifically looking at the gums. And we use different instruments to do that. My main instruments, I have a mirror, a little pokey thing that patients like to say it's my explorer. Clinicians, dentists, hygienists, were trained to feel underneath of the gums. So we have instruments that we are very thin, but they do have a pokey tip, and that's for us to use to assess. So we're feeling underneath of the gums, and then I have a periodontal probe, typically has markings on it, kind of like a ruler with measurements in millimeters. That's going to help to assess the health of the tissues around the teeth.
Does everyone get their gums measured?
Everybody should have their gums probed because it's just part of the assessment phase. Whether we're assessing health or disease, you have to assess it, you have to record it. We have to have a starting point, especially new patients that come into an office. We need to know where we're starting from, because what happens when 5 years down the road, we don't have a starting point, and now all of a sudden we have 5 millimeters of recession, and you're asking, is it getting worse? Wish I could tell you, because if we don't have that starting point, how can we tell changes over time? If we're in a disease state, same thing. If we're starting from bad and we want to go to good, how can we tell if there's a change if we didn't get that initial starting point?
Is there a certain age that you typically start charting?
Yes, but also no, there's no definitive age. If I see a child with permanent teeth with inflammation everywhere, then I am still starting that starting point. There's a lot that happens through adolescence and the mixed dentition that has significant changes, but typically if we're in a state of disease, so inflammation, bleeding, you want to record that so that you can see the changes.
And what is a periodontal chart?
Very rarely do I show a patient a periodontal chart because it kind of looks like a blank Tetris block. There's several lines on it that measure different things. So first and foremost, we do what is the probe depth. So that is measuring from the top of the gums down to where the bone connects underneath. Again, we're measuring in millimeters. 1 to 3 millimeters we'll consider normal or healthy. 4 millimeters, we can definitively say there's inflammation there. 5 millimeters and greater, just too deep. Second line on a periodontal chart is what we call the gingival margin. So that is the difference between where the gums are and where the gums are supposed to be. It essentially measures recession. So we add the probe depth and the gingival margin together, the calculated attachment loss. That helps the dentist in determining what stage of periodontal disease the patient is currently at. And then we'll also measure bleeding, measure called exudate or pus, that is significant infection, have what is called furcation involvement. If you think of like the roots of your teeth like a milk stool, if we have bone loss that goes past the legs of the milk stool, then bacteria can actually get underneath of your tooth, which is called the furcation of the tooth. Usually at that point, prognosis of the tooth starts going down pretty rapidly. That doesn't mean you're going to lose your tooth right away, but it does mean that the care that you need to devote to that tooth to keep it any length of time does significantly increase. This is a solid 20 minutes of work right here.
And we also use the x-rays to diagnose with that chart. So that chart is really, really important to figuring out what kind of cleaning you actually need.
Yeah. Gingivitis is inflammation. It doesn't involve bone loss or loss of connective tissue, bleeding of the gums. And usually there's not a whole lot of pain involved at this point. With improved oral care consistently, gingivitis is reversible.
We diagnose staging and grading if you have periodontal disease. Can you talk to us a little bit about the difference between the two?
There are different stages to periodontal disease, 4 stages, and this is actually where we begin treatment for periodontal disease or periodontitis. This is where we have probe measurements of 4 millimeters or greater, 5 millimeters or greater, calculated attachment a loss of at least 3 to 4 millimeters. We have same things as it's starting to get more tender at this point. Again, left untreated, it continues to progress. Stage 3, you have greater than 5 millimeter pockets. You have everything is stage 2.
For stage 3 is the tooth loss if there's less than 4 teeth lost from perio.
Stage 4 is just advanced. So we're starting to have functional problems by this point. Sense of tooth loss, drifting of teeth, tooth mobility issues. You're having a hard time chewing. And then eventual tooth loss. So it does progress through the stages, is non-reversible.
We also have grading system. There's grade A through C. And so grade A, there's no extra loss over the last 5 years. Grade B is if you've had 10 cigarettes or less. And then if you've had more than your grade C, it's like a health modification versus a stage is more of a clinical, and grade is history as well as risk factors. How often should people actually get their teeth cleaned?
I love this question. Did you know that the 6-month recall was not created by dentists? It was created in the 90s by a toothpaste manufacturer and their marketing campaign. So I love this question because it's so subjective. This toothpaste marketing slogan was see your dentist twice a year. And at the time, there was no standard of care as far as how often you were supposed to see your dentist. Lawyers, insurance companies, and dentists all started accepting the 6-month recare regimen because they did see a patient twice a year and something happened within that twice a year time frame. The liability went down because they were following what was the standard of care. As far as how often you need your teeth cleaned, if it's a healthy patient, every 6 months. Now, if you're medically compromised, dry mouth, diabetes, other medications that you have to take for other systemic diseases, 3 to 4 months. The bacterial cycle. The bacterial cycle is actually 90 days, especially when we're treating patients that have active infection or that we're treating active infection. If we're not seeing them every 90 days or shortly after 90 days, we're not interrupting that bacterial cycle. To promote health, we need to interrupt that bacterial cycle. That's a great, why every 3 months? I just got my teeth cleaned. Why do I need to come in every 3 months? It's because of that bacterial cycle. Bacteria starts to become harmful again after that 90 days. We see you at 90 days. We interrupt that cycle. We start back again. And then we're significantly reducing the amount of bacterial reproduction that continues to happen.
What kind of signs or things that can someone look out for to see if they have periodontal disease or gum infection?
If your gums bleed when you brush or floss, it is not normal. In an otherwise healthy patient, if your gums bleed, it's not normal. If your hands bled every time you washed them, would you be concerned? Because you should be. It's not normal. Bleeding, number one. It's our body's reddest red flag that something is wrong. And our body is telling you, pay attention. Look at me. Something is wrong here.
I've heard a lot that some people say, well, I just brush too hard. Is that a thing?
Possibly. But if your gums are infected and you brush hard, they're infected. And that's why they're bleeding. And if you say, I don't floss because my gums bleed, they're bleeding because you don't floss. Unfortunately, that is a vicious cycle. Continuing to remove the bacteria or flush out the bacteria. I'm a big fan of water flossing. Flushing out the bacteria on a regular basis, and I mean daily, is more effective than flossing twice a year and saying you're getting it done. So you're brushing, the tissue's already in a state where it's easier for it to bleed because it is infected.
How long does it take, like if someone has bleeding gums, for them to start feeling normal if they're really diligent about their oral hygiene and flossing?
2 to 3 weeks. On the reverse side of it, if you don't take care of your teeth for 2 to 3 days is when infection sets in. It goes back to an age-old prevention is so much easier than restoration. It is so much easier to stay on top of things than it is to fall into a disease state and try to get back to healthy. If that's not all the effort you need to get out of bed and do the oral hygiene thing, brushing and flossing or water flossing, I don't know what else is.
I've also had patients that if they were struggled with like depression and couldn't get out of bed for days, I mean, even having a toothbrush next to their bedside, it doesn't even have to have toothpaste on it.
Toothbrush and water are all you need to do something. I'll go back to the 60% is better than 0%. Life can be real, life can be raw, and sometimes it really sucks. but something is always better than nothing. The mechanical removal of the plaque with the toothbrush is better than nothing at all. You're mechanically disrupting that bacteria. When we're disrupting that bacteria, we're forcing that bacteria to pretty much have to rebuild. Whereas if we're not disrupting that bacteria, then it becomes more and more destructive. Also, water, biggest thing. Patients with dry mouth, patients that haven't brushed, they've been drinking soda all day. To flush the bacteria just kind of sitting in your mouth away, toothbrush with no toothpaste and swishing with water, so much better than nothing at all.
We kind of touched a little bit about the differences between the cleanings and diagnosing. Can you kind of just give like a basic, if someone is getting a general prophy, is what we call it, general cleaning, versus the scaling and root planning, or an SRP that we call it?
Absolutely. So a general cleaning or prophy is for normal, healthy patients. And what we're doing during that procedure is cleaning generally above the gum line. We'll go slightly below the gum line. The focus is above the gum line. We're polishing to help remove extrinsic staining, removing tartar or calculus deposits from the teeth. We're removing biofilm from the teeth. In my clinical practice, I use ultrasonic scaling to help irrigate the gums, flush out that bacteria. Now, the difference between that and scaling and root planing, general cleanings are preventative in nature. Scaling and root planings or deep cleanings are therapeutic in nature. So they are meant to be treatment for periodontitis or periodontal disease and significantly more involved. Yes, we do all of those things. I personally don't polish during my initial treatment because I don't want anything kind of getting into the gums that shouldn't be there. So we generally work under local anesthetic for that. Usually makes the patients more comfortable because we are working on the root surfaces of the teeth primarily. You'll want to be numb for that procedure. In my practice, I use ultrasonic scaling for that as well. We're removing those tartar deposits from the teeth. You can also have adjunct therapy to that as well. So you can have antimicrobial agents that we'll place underneath of the gums to help treat disease and infection. Some clinicians will use laser therapy, which is amazing. It's just significantly more involved, and it's meant as initial treatment versus preventative treatment.
And typically you do it in 2 visits at least.
At least. Why we do it 2 visits. It's not to make your schedule that much more inconvenient, we promise. Giving anesthetic, one, you don't want to get the whole lower jaw numb at the same time. Not because, we'll do it. It doesn't harm us at all. But when you walk out and you bite your tongue or your lip or your cheek because you can't feel anything, that's why we don't do it. It's for the patient risk factor. We don't want patients to hurt themselves after they leave our office.
What are some expectations for patients if they do have the deep cleaning? Are they going to be sore? How long the recovery time is? Can they go back to work the next day?
Yes, they can go back to work. It's not like having surgery in a sense that you're having like a tooth extracted, because scaling root planing is a non-surgical treatment. We're not cutting into the gums at all. We're actually just deflecting them so we can gain access. It's not in a sense that you're having like initial closure or full healing in an area. So it's more just soreness or tenderness. So think like you flossed really, really hard is what it's going to feel like. So going back to work the next day, I've had patients go back to work the same day. That's up to the patient. As far as expectations, what we do in the office is only as good as what is done at home. We do initial treatment. We get the teeth bright and shiny and clean, and then nothing is done until we see the patient the next time. We're not going to have improvement. We might have some, depending on where we started from, but if nothing is done at home, or if habits that have led to the current situation don't change, then we're not going to see progression in the right direction.
And after the deep cleaning, then do you do a follow-up 6 weeks after?
Typically, yes. Some patients will say, why do I need to do this? Well, I'll tell you why. Because you just devoted probably a solid 3 to 4 hours of your time, and I devoted 3 to 4 hours of my time, and I want you to be successful. Usually when we start treatment, we're significantly inflamed. 6 to 8 weeks after treatment, we have reduced inflammation, which gives your hygienist increased visibility. We can see more. So if we missed a spot, we can see that, we can remove it. That's for your benefit. We take secondary probe measurements. We want to see those probe measurements getting smaller, but also we want to make sure that you have all of the tools that you need to be successful at home. Saying, well, you recommended this water flosser and I don't know how to use this. Cool. I would love to show you how to use it. Or I'm doing an assessment and I see that we're missing this one area. Okay, let me show you how to get to that area so that we can be successful. We are not just throwing you out into the wild and saying, okay, good luck, bye. Maybe we'll see you next time. No, we want you to be successful. So it is a follow-up to not only ensure that our treatment was what we expect it to be, but also that the patient has everything that they need to continue to be successful in their journey towards increased better oral health.
After you do the deep cleaning and you remeasure their gums after the 6 weeks eval, can they ever go back to the 6-month cleaning?
Will you go back to a normal, healthy cleaning, prophylaxis type cleaning? No. Can you go back to a 6-month recare interval? Yes. Does it take a long time? Yes. So the difference between what we call periodontal maintenance, which are those cleaning appointments after you have initial treatment, the difference between that and a prophylaxis or prophy is you are no longer a healthy patient. We are maintaining your periodontal condition. So it's possible to become a stable periodontal patient, but you still have bone loss. You are still more subjective to increased infection. You have more risk factors. So we have to treat those risk factors by saying that, sure, you can go back to 6 months. That's your choice. I mean, it is your choice. We can't force you to do anything, but we can recommend that you stay on a 3 to 4 month recall so that we can continue to help you stay healthy. I have had patients that I have seen for years and years and years and years, and I see them every 6 months. They also have zero bleeding. They are not diabetic, follow a oral hygiene regimen that is probably better than mine, because when you do have increased risk factors, you have to try harder. You have to brush more diligently. You have to floss more diligently. You have to be aware of so much more because you're at a higher risk. So no, it's not impossible to get back to 6 months, but it takes time, effort, diligence, all of that to get there.
To simplify the basics of if you have a cleaning prophy, you do not have bone loss. If you have a deep cleaning or SRP, you have bone loss. And so that
Correct.
periodontal maintenance is only for people that have the bone loss, and it's those 3 months that are recommended for the rest of their life so that they don't go backwards, because the
Correct.
goal of the maintenance part is that we want to maintain where they're at. There's a specialist called a periodontist, and they do what you do, but also do surgery and other things. When is there a time where you're like, hey, I need to send you to a specialist?
Usually when treatment is recommended, it is a joint effort between the dentist and the hygienist. If there is ever any doubt, we have this saying, if there's doubt, refer out. That means we are unsure of the prognosis for a multitude of reasons, or we are uncomfortable treating that specific situation. There can be lots of factors played into that. But if we don't think we can be successful, then we're going to send you to somebody with more training than us. So is there like a certain probe measurement? Yes and no. I'm comfortable treating a lot of different areas, but I have to have the support of the dentist that I'm working with to treat that. Some offices will say, 7 millimeters or greater, they're going to refer to a periodontist. I have had 6 millimeter pockets that I've had to refer to a periodontist because depending on the area, I may not be comfortable treating it. Or if there's significant recession in an area and a tooth is already mobile and maybe it's not only related to disease, it could be related to something other than disease that is causing the problem there, it's better to refer to a specialist than to continue to treat an area ineffectively. On the other side of that, if I've been treating a patient and we're just not getting better, I'm going to refer you to a specialist, because continuing to do the same thing without progression, that's like the definition of insanity. You're not getting better.
Why is oral health so important for overall health?
This is an entry point into your body. If it's infected, everything you put into your mouth is spreading disease all over your body. Inflammation has been the link to so many cardiovascular disease, Alzheimer's, diabetes, and periodontal disease are directly linked. One directly affects the other and vice versa. So disease, inflammation, it's all over. You have to treat it.
Have you noticed any trends or changes in hygiene care over the years?
And this can kind of go back to my slight rant on insurance and the pressure that insurance companies place on dental offices. There is a pressure to see more and more patients, which ultimately affects the care that is able to be given. Not a good situation. And I think there are a lot of hygienists that are still continuing going to try to do the very best that we can, but there is downward pressure to do more with less, and it's extremely unfortunate.
How do you approach cleanings for kids or people that potentially have some anxiety or nerves?
Love this question because it's always that first appointment. I like to think that I can make any patient smile, even if the first thing they told me was, I don't want to be here. Cool, but I'm here and you're here and we're going to do this. It's always a risk versus benefit. If I do the 100% cleaning that my hygiene heart wants to do and I traumatize that patient so where they never want to come back, I have done more harm than good. I will try to make my patient as comfortable as possible, while also understanding what I'm doing and why. If at any point my patient says, I don't want to do this anymore, okay, we're done. If we get 3 teeth done, goes back to that, something is better than nothing. And especially for very, very nervous patients, whether it's elderly, medically compromised, children, if they're traumatized when they leave, they're not coming back. So I would rather do something, make them comfortable. It could be asking questions, showing them how to properly brush their teeth. Maybe it's not a full cleaning. Maybe I showed them how to floss. Maybe we talked about why they hadn't come to the dentist in the last 10 years. Life's been rough. Okay. But that patient then had some real human connection and may not be as afraid to come back next time. And maybe we'll get more done next time. So it's not always about, 100% of the clinical every single time. It's about being human to human, trying to do the best that we can, doing the most good with the least amount of harm.
It's even helpful if the cleaning aspect doesn't even happen, just be seen for an exam and getting all that medical history and measurements and all of that, and then coming up with a game plan. Even if they just need a prophy, it's not the end of the world. The big picture of understanding like what typically happens in an appointment doesn't necessarily mean it needs to happen for you, and knowing that there are options. Again, we can tailor it to you as best that we can to try and help get rid of that fear and help with the education base so that you actually understand what's happening.
Yes, all of that, because every patient is different. Every circumstance is different. Designing a treatment plan from start to finish per patient will always render the best results.
Do you have any tips for parents trying to help their kids build good habits early?
Make it as fun as possible. What I mean by that is kids don't want to do things that they are told they have to do without explanation. I was one of those kids. I didn't start flossing my teeth until I went through dental assisting school because nobody told me why. They just told me I had to. So one, making it fun. For example, when my daughter was really small, we would lay on the couch and she would put her head in my lap and she would get to hold the flashlight so I could see in her mouth, and I would look in her teeth and I would count her teeth and we would giggle and I would floss her teeth, and it became a normal feeling for her to be able to floss. Also, I think demonstrating proper oral health to your children is incredibly important. If you do not floss, your children will not floss. They will not say, why? You don't do it. Why should I? Valid. Kids are really great about calling us out. If your child is adamant day after day after day after day, and it becomes a kicking and screaming battle, try something else because it's not making the situation better. So there are a lot of resources online to help with certain circumstances. I know every child is different. What I did with my kid may be completely different to how you need to address your children, but there are resources online that are specific to my child has a fear. I can't do this. I can't do that. Talk to your dentist. Bring them to the dentist. Bring them to a health fair. Seek resources if you're struggling. But there are some really great fun apps out there too. So just look, ask the questions. Don't just say this is how it is and he won't let me brush his teeth or she won't let me floss her teeth. Continue to keep trying.
That's even a good point. If the kid is really nervous for coming into the dentist for the first time, you can call the office ahead of time and you coming in and just meeting everyone and not doing anything. They could sit in a chair, just see what's happening, and just so that the next time that they come in, they understand what's going on. Because I know that is a big fear and just the unknowns of what a dentist is. And a lot of people just talk about their horrible experience they had, as then that brings fear into the kid himself, and just a trickling down effect too.
We want it to be a good, happy experience, not a bad one.
Do you have any advice for people that have told their kids, I'm a dentalist, I don't have any teeth because my teeth all rotted because they're brittle or your teeth are going to look like mine if you don't brush, like the fear factor of that?
I think it's not always placed right, especially in children. Children don't understand the whole process. They may think that dentures are an easy out. Okay, well, if I lose my teeth, I'll just get dentures. Dentures are a replacement for not having teeth. They are not a replacement for teeth. And children, and some adults, don't understand that part of it. Having the fear factor placed to an extent, I don't think children want to lose their teeth, but you don't want to give them an easy out to not take care of their teeth either. Because, once the damage is done, the damage is done. Even restorative dentistry, we can restore the teeth partially, but it's never as strong as your natural teeth, unfortunately. We can replace teeth with implants. It's still not your natural teeth. It's different. What's the statistic? It's like with dentures, you may have 20 to 30% of your natural chewing capacity with dentures, but also with parents that tell their children that their teeth will end up like theirs. It's like a 30% hereditary factor of teeth that you can change your cards. You may have to work harder. You may have to brush more. There may be, some dry mouth in the family. There may be some other factors that play into that. But just because a parent's oral condition is one way does not mean that a child's will be the same.
Yes, it is possible to change. Again, like you said, it's not easy, but it's totally worth it. If someone hasn't been to the dentist in years and they're embarrassed, and I know you talked about this a little bit earlier, but what do you want for them to hear so that they can be more comfortable and show up to their appointment?
The first appointment's the hardest, and we are just genuinely happy for you to be there. Whatever we need to do for you to be in the chair, to make you comfortable, to address your concerns, you tell us what you want. What are your goals for your teeth? When I meet a new patient and I've done the health history and I've taken the x-rays and we've sat down and we've started talking, that's usually my first question. What are your goals? What are your concerns? Because that's a great place to start. If your goal is, I don't want to lose my teeth, great. We can start there. What it takes to not lose your teeth, what our current condition is, and maybe we will have to lose some teeth, but at least we have a starting point. We're not there to judge you. We want to make it possible to do what you want. Now, if we have a patient that comes in and says, I want you to just pull all my teeth. I'm going to try to talk you out of it if it's possible, because we like to save teeth if we can, even if it's just a few. But if it's not possible and life circumstances say we shouldn't, then let's talk about it. If you come in and you're nervous, but you don't tell me that you're nervous, then how do we know? So let's just communicate. We're not robots. We're not heartless. We actually come to work and we have lives outside of the dental office that we've lived. We've been there. We've all been through it with patients.
Do you wish patients knew about preventing gum disease and tooth decay?
Sugar and anything that breaks down into sugar. It's the root of all our problems with our teeth generally. So with sugar, it's different coming to the dentist of what we're going to tell you with sugar than it is going to your physician. Your physician is going to say your overall sugar consumption is what matters. A dentist is going to tell you when it comes to your teeth, it's frequency, not total amount. If you want to have 15 Coca-Colas a day, better drink them all together. I don't know what that's going to do to your stomach, but it's going to be a lot better for your teeth. So the thing with that is every time you take a sip or a bite of something, you are exposing your teeth to sugar or things that break down into sugar. The bacteria in our mouth then metabolize that sugar into acid. Acid then sits on your teeth and acid starts to demineralize the teeth, which leads to cavities. So if you reduce the frequency in which you're exposing your teeth to the sugar, you're going to reduce your risk factor for decay. What that means, limit snacking, keep your sugary non-water drinks to meal times, and drink water throughout the day and drinking through a straw.
We're not condoning 15 a day, but
no, we're not.
What are a few things patients can do at home to maintain great oral hygiene between visits?
Brushing, flossing, water flossing. Brushing, if you can get to an electric toothbrush, yes. Electric toothbrushes take the human error out of brushing. It usually makes us brush for the full 2 minutes, and it's also getting more brush strokes onto the teeth to get that mechanical removal of the plaque. Flossing. Flossing is great because we want to break the contact in between the teeth to get any plaque bacteria that can reside right in between that contact. But outside of that, you get something stuck in your teeth, like a food mass or something like that stuck in your teeth, you definitely want to use floss to get it out. I am a huge fan of water flossing. Why I like water flossing versus traditional flossing is because traditional flossing can be very technique sensitive, whereas water flossing, if you can get the water in the general area, you're going to start flushing away that bacteria. However, caveat to that, using a water flosser is like taking your car through a cheap car wash. You have to do it every day. If you take your car and you go run it through the mud and think running through the cheap car wash is going to get it all off, it's not. So water flossing, but you have to do it every day.
And how many times are you supposed to brush, floss, and water floss?
Brushing at least twice a day, water flossing at least once a day. Well, diligently, not just popping the floss in between your teeth. That's not flossing.
And ideally before bedtime.
Yes, 100% before bedtime. The difference, we don't want all of that sitting on your teeth while you sleep because we have reduced tongue movement, reduced saliva flow, more risk factors for disease and bacterial reproduction at night than we have during the day. So clean your teeth at night to save your teeth and clean your teeth in the morning to save your friends.
That's awesome. I've never heard of that. What are some of your go-to products that you like to use?
I like sonic type toothbrushes. The reason why I like sonic type toothbrushes is because it is a more traditional type toothbrush head. It just kind of brushes back and forth, whereas the small circle toothbrush heads, you do have to brush a little differently, but it is all preference based. Flossing, I like floss that you can get in between your teeth. It depends where I'm at. If I'm in my car, I think floss picks are great. If I'm out and about, floss picks are great. If I am at home, I will use string floss. I have more control over the string floss. I think I can be more intentional with string floss. And then also a water pick or a water flosser. Just about every dental manufacturer has a water flosser these days. So it's all about preference. I will say that if you can get a water flosser that is rechargeable and like the cordless ones, you can take them in the shower. It makes the whole process so much easier simply because you don't have to worry about the mess. And if you take a shower every day, which most of us do, you can incorporate it into your daily routine very easily.
And definitely don't put the water flosser on like high.
Yes. It should feel like a gentle massage, not like you're pressure washing the tissue off of your teeth.
And be careful with the water picks too, because that can damage gums as well. Do you use a tongue scraper? Or do you recommend a tongue scraper?
Yes, I do. If you've never done it, it can be quite enlightening. Bacteria like to sit in all the little villi, the little projections that come off of our tongue. So we do need to get that off. I know there are some manual toothbrushes that have like a little scrubber on the back side of the toothbrush that you can scrub. Some people will recommend having a different toothbrush that you scrub your tongue with. I am a bigger fan of a dedicated tool like a tongue scraper. That's just what they're designed to do. Now you don't need to do it to the point where you make your tongue bleed, but it does significantly help to reduce the bacterial load within the mouth.
Do you use mouthwash, and do you recommend any?
I use mouthwash occasionally, probably not in a sense that most people do. I am not a fan of mouth rinse for me. There are instances where I absolutely recommend mouth rinse, and it's usually for specific reasons. If we have a high risk of decay, I'm going to recommend a fluoride mouth rinse. I think there's some great over-the-counter mouth rinses like ACT. If we're just trying to have some fresh breath because we're going to go into a meeting, there's some mouth rinses for that. One of the good ones is like Scope, but it's just a breath freshener is what that is. The type of mouth rinse that I do recommend to patients are oxygenated mouth rinses. They're usually peroxide based. Some different brands are like Closis or Proxil. They have peroxide in it. Oxygen molecules inside of that mouth rinse help to work on the type of bacteria inside of our mouth. So the bacteria that cause periodontitis is the type of bacteria that do not like oxygen. So when you use an oxygenated mouth rinse, it's more effective. Now, the kind of mouth rinses that I do not recommend are the kinds that have alcohol in them, specifically because of the drying effect of alcohol. So yes, alcohol does help to reduce bacteria, but it also creates an environment in which bacteria grow. It's always a risk versus benefit. I think the benefit of an alcohol-based mouth rinse does not outweigh the risk. There are better options.
What's one myth about cleanings that you'd love to debunk?
We're not trying to hurt you. Cleanings can be uncomfortable, but it's not because we're intentionally trying to hurt you. There are conditions in the mouth that make cleanings more uncomfortable, like infection, inflammation, decay, recession. Sometimes it just makes the teeth more sensitive, and we are not trying to hurt you, and we just want to help you. When we have patients that are mean to us, we're not being mean back, and we just want to help, but it doesn't help when we have really negative patients. If it gets to the point where we have a patient that's just really uncomfortable, we would just rather prefer a patient to say, I don't want to do this anymore, and we'll call it what it is. There's something else that needs to be done first. If we have rampant decay, maybe we need to take care of the decay first, or maybe we need to plan a cleaning in which we use local anesthetic for, or some other situation. If we have a patient that is adamant that they get a cleaning done and that we're just being too rough, we might just have to disagree.
There may be some hygienists that are a little more heavy-handed, though. Typically, there's more than one hygienist at a practice, so it is possible to see if there is someone else that they could see to see if that is better for them, to suit them.
That's a great point. You can always ask to see somebody else.
And same thing with doctors. Like if there's more than one doctor in a practice, if you don't like how they're explaining something or whatever, you can ask the front desk, see if there's another provider available. It's not something that we take personally, because not everyone's going to like us. It's just some people mesh better with others, and that's okay.
Patient-clinician relationships are incredibly important. And if you're not comfortable with the dentist, hygienist that you are seeing, absolutely ask to see somebody else.
I have bad breath. What are some things that I can do to help with that?
Make your dental appointment first and foremost, especially if it's been a long time. A lot of times, if you call a dental office and you are not in pain, it will be several months before they get to see you. So if you have a concern that is non-urgent, go ahead and make that appointment, because it's going to be a little while before we can get to it. Most dental offices are booking out 6, 7, 8 months for a non-urgent appointment. Second, start looking at your gums. If they are red, swollen, bleeding, we might have a potential for where that bacteria that may be producing that bad breath is from, and start evaluating your habits. If you aren't brushing twice a day, let's start there. If we're not flossing, maybe add that. If regular flossing is really painful, maybe try a water flosser first. And definitely in cases where we have a lot of tartar buildup, you may not even be able to get floss in between your teeth. So start with a water flosser on a really low setting that we're helping to flush that bacteria away. Also, bad breath can oftentimes be related to bacterial accumulation on the tongue, addressing that tongue scraper. It also can be related to something not related to your teeth. So if you haven't been to your primary care doctor in a while, you may also want to make a primary care doctor appointment.
Any ways a patient can prepare for a dental hygiene appointment?
Don't expect to get in and out in 40 minutes. It's going to be a longer appointment. It is better to expect your dental office team to be thorough than to expect a lot of treatment to be done. Be patient, especially if you're in an office that is either understaffed or has a high patient volume. Public health offices especially, there usually is not enough to go around, and everybody there is trying to do the absolute best that they possibly can. Preparing, have your medications list, be patient, come with all of your documentation. If you can show up, 20 minutes before your appointment, that would be great. We would really appreciate it. 1, we know you're coming before your actual appointment time. 2, you have time to fill out any paperwork that you may need. And 3, if there's traffic, great. You have a few extra minutes to get there on time, because we know life happens outside of our dental office, but the time isn't made up. Your appointment time starts when your appointment starts. Now, there's the other side to that, whereas I was here 20 minutes early and I didn't get back until 20 minutes later. You're right. We are usually so apologetic for that. Unfortunately, dentistry is one of those things that once we start, we can't say, okay, well, your appointment's over, we're done. It doesn't work that way. Very different to when you go into a medical office and they say, okay, well, we're done now. We'll do that next time. It's more relative to surgery when you are booked for a certain day, and you will find out what your time is when you get there. So being patient, being kind, we'll do our very best. You do your very best. We'll get through it.
Yeah, I think the big thing on time, and if you have something to be somewhere else, else at a certain time. Let people know the second you check in so that if we may need to reschedule or we may only be able to do part of it on the doctor side, if we're doing fillings or extractions or whatever, I can't do it in a certain allotted time.
Hmm.
Sometimes things pop up, or sometimes I have a couple rooms that I need to get to. And, even with like waiting for an exam and the hygiene side, if I'm stuck in a procedure, it's okay to say like, hey, I need to go and we can get you scheduled back for just an exam with the doctor. We can be totally accommodating if we're just aware. I'm
Yes.
hoping through this interview that people actually understand everything that's going on so that it's not just one-sided thing for those. Any final thoughts on what people can do to take charge of their gum health?
Make that appointment first and foremost. Like, you can't do it alone. Dental health does not get better over time if left neglected. 100% of patients will build tartar. You could be the best brusher, flosser, have exceptional oral health. You will still build tartar. So you have to see a dentist. It's a non-negotiable. 100%. If you do not have a dentist, you need to find one.
Alison, thank you so much for sharing your knowledge and experience with us today. From your journey as a dental assistant to becoming a hygienist to breaking down what really happens during a hygiene visit and how patients can take care of their oral health. I hope this conversation gave you a better understanding of what your hygienist is looking for, what your gum measurements mean, and how you can be proud of your smile. If you found this interview helpful, please give it a like, subscribe to Gentle Dental so that you don't miss future conversations, and drop a comment below sharing what you learned today or any questions you still have. We love hearing from you, and we'll feature your question in a future video.